Here we go. Dr. Josh Luke here with the Health Wealth Podcast. I'm very excited to get to the interview portion of the podcast series now that we're done with the Health Wealth Basics. And we're actually going to kick off the interview portion of the Health Wealth Podcast and radio show with someone who I've actually gotten to know on social media but never actually talked to before. So I'm excited to talk today to David Contorno. He's the president of Lake Norman Benefits. And we actually haven't spoken for more than just a minute or two before this interview because I like to get to know my guests as we go. So what I want to do is just start by asking David to introduce himself and tell us a little bit about his company and what they do.
Great. Happy to. So my name is David Contorno. In the industry when I was 17 years old up in New York. I was born in the New York City area and did most of my early career up in Long Island. And I was the typical broker advisor, putting spreadsheets together and showing them to clients and hoping that I was the least bad news on the spreadsheet. And we had a nice little business going. But in 2007, my wife and I decided to do a change of life, move to North Carolina, and I kind of call that my 2.0. I use that as a pivot point to try and do things a little differently. And admittedly, it wasn't all that different. The market was largely dominated by one carrier in this area, and we came in with another carrier that we had a previous good relationship with, and we were very disruptive to the marketplace. But there's a story that I give. It's a true story. It's not a made-up story. That was the pivot for my 3.0, which is where I feel like I am today. And I think it's going to be very germane to the conversation we're going to have today. So I'm real quick. Lucky enough that I drive a nice car, and one of my biggest time hacks that I found is I have a driver on staff. So in between meetings, I'm able to get work done. And so a few years ago, one of my salespeople had taken a lumber manufacturer from a very high-end Blue Cross and Blue Shield plan to a very low-end other carrier plan, let's just say. Okay. And the employees were struggling with the increased out-of-pockets. So I went in one day to try and save the account, and I asked the CFO to have some of the employees come in with some of their exact problems, because I first wanted to understand, is the problem really the benefit level, or is it claims not being processed properly or filed properly? So I come into this little conference room, and there's two women sitting over there with some bills, and I start talking to them and going through it. And as I'm going through it, this rough and tumble lumber manufacturer guy sits down quietly at the table and just sits there. And I continue to help the two women. And I met them after about 20 minutes, and I turned to this gentleman and I said, "Okay, sir, how can I help you today?" And he says, "Don't blow smoke up my ass." And I said, "Excuse me?" He said, "Don't blow smoke up my ass. I saw you driving here in your $125,000 car with your driver, and I have medication for my wife's multiple sclerosis that I can't afford anymore. And she's going unmedicated right now. And her life and my life is miserable as a result." And he actually got in my face, and I don't, in retrospect, I see that as a pivot point. I'm not sure that there was an awakening at that moment, but what I realized was the worse results that I delivered to my clients in the traditional model, the more money I made. And that just felt wrong to me. And so if I'm going to make money over someone not being able to afford their medication for their wife's multiple sclerosis, that's not a position I want to be in. And so I said, wait a second, why are we delivering horrible results? Everyone keeps saying it's underlying healthcare. Carriers say it, the hospitals say it, everyone says that that's the problem. So why are we not focusing on that problem? And so I started to dig into that and found incredible dysfunction, incredible lack of transparency, incredible perverse incentives across the board. And so that was sort of what started down the path that we are on today, which is really a simple twofold strategy. We need to identify where the costs are going. And luckily in healthcare, higher quality typically costs less. So what if we could drive people to higher quality facilities at a lower price, and then put employers into a insurance environment in which they benefit from those decisions? I mean, that's really what it comes down to. So that's where we are today.
That's a cool story, and I appreciate you starting us off with that, because I think that really gets to the heart of what we're here to talk about today. So what I heard from that story, the short version is have an Uber driver instead of a personal driver, and drive an inexpensive car with your Uber when you go to a new client meeting. So
or deliver a ton of value where they're happy to pay you enough money to be able to afford those things.
That's right. So cool. That's a great way to start. I'm going to do a little pause here because I want to back my chair up and I want to grab a copy of my book so I later don't have to interrupt.
Sure.
Okay. Without stepping on it. So that's a great story to get us going. And for those of you who haven't listened to the Health Wealth podcast and radio show before, our goal with the whole Health Wealth movement, which you can find at health-wealth.com, is really to help make healthcare affordable in America again and to reduce spending for businesses and families. The core audience of our podcast and radio show is business owners, CFOs, those in charge of finances and HR for Fortune 500 and 1,000 companies. And really, I've made that my personal mission. My Forbes book came out in January 2018 called Health Wealth is Healthcare Bankrupting Your Business, 9 Steps to Financial Recovery. And I want to talk a little bit further about that because David kind of touched on one that I wrote about, and it's been a fun topic because now I've been getting hired for the last couple of years, more so in 2018, to go speak at broker events for employers to grow their volume. And it's hard to talk about what David just talked about. And even though, now would you call yourself a broker, David? Are you a broker, in fact?
I mean, in the traditional vernacular, I say that because that's what people understand, but we're really more of a consultant or an advisor, especially in the way we get paid supports that even more so.
And it's so cool that you said that because there's an entire chapter in Health-Wealth that talks about that, wow, this is so sensitive, you can't even say it without having to apologize. But chapter 4 of my book, and I know David is an advocate, and he's going to tell you a little bit more about the Healthcare Rosetta, and we're going to have Dave Chase on an episode soon as well, who I believe is one of the founders of the Rosetta. But the chapter isn't about necessarily the Rosetta, but if you really read through it, it's about the process the Rosetta goes through, which is an independent audit of every penny that your organization spends on healthcare, whether it goes to the carrier, to your broker, or to a provider, if you're self-insured, wherever it goes. We want to build an Excel spreadsheet, and we want to know where every penny's going, and then we're going to audit why, and did we overspend, and did we get our value, and where is the waste? And what David's talking about is you'd be amazed at how few brokers really realize how important it is to kind of have that disclaimer. Well, in the traditional sense, I'm a broker, but really I see myself as somebody who can bring value because brokers, like realtors, are people that traditionally are getting compensated more when their client spends more. So tell me a little bit about, again, one of my 9 steps to financial recovery is what I call a complete audit. And so before you kind of get into more about the Rosetta, is there anyone out there that does an independent, quote unquote, audit of every dollar a company's spending that doesn't have some skin in the game? And that's a big asterisk at the end, right? Because there's a lot of people who claim we're going to come in and do an audit. I mean, that's what a broker does every time they're going into a new client, right? But is there truly anyone out there, David, that can come into an organization and do an independent audit without you having to worry he's just trying to refer business to his broker? And if so, who are they?
Yes, there are a few, and I kind of bulk that into 2 buckets, or maybe even 3. Pharmacy and medical, I think, are segregated. We need to separate those out. And then even under medical, there's really kind of 2 audits that we do or have done. One is holding the payments, the integrity against the network pricing. So when a client has a network, and we're big believers of getting rid of the network whenever we can and bringing in reference-based pricing, but for a minute, we can't get rid of that network. There's 2 levels of audits that we'll do. Level 1 is the payment level. Was it actually in line with the contract? Because if you get if you're an employer and it says the gross bill charge for a hospital stay was $100,000 and it's with Cigna, and Cigna gets a 40% discount, so you only pay $60,000 for that claim. How do you know it's not supposed to be 42% with that provider? Because it differs with every provider. Sometimes it even differs with one provider within the same healthcare system even. So there's an audit against the actual payment level. That's audit 1. But then audit 2 is, okay, so if we were supposed to pay $8 for this and we actually paid $8, was that even a legitimate charge to begin with? And that's a different audit. It can come from the same company. Actually, for that side, we use the same company. But there's multiple different aspects to audit it. One of the things that we try to do is not just with the transparency and how we get paid, but with every single vendor across the board, the TPA, the stop loss vendor, the PBM. We don't want them having those perverse incentives either. We want all of them not benefiting from costs going up. And so we try and keep everyone to have aligned incentives across the board right from the start. And that actually makes it a lot easier to come in and do the audit, because now they don't feel like they're being checked up on as much. So a lot of this is follow the money, try and make it so that everyone benefits in an aligned format. And then holding everyone accountable to those things become much easier. When you're fighting against a network or a carrier or a TPA that doesn't want certain things found out, they make it much more difficult to do this. But if you set the tone right from the beginning, well then, yeah, everyone.
So chapter 4 of Health Wealth, is healthcare bankrupting your business, is called Conduct an Independent Carrier and Broker Expense Review. And so that's what we're talking about. So if this topic is of interest to you, I would encourage you to check it out in the book, but also we're going to have an interactive series that comes out. And I want to tell you a funny story about how the first time I ever saw David's name was in the copy field of an email. As I got to know Dave Chase, Dave and I met at a speaking gig, and several people had said, you two are so much alike. But what's interesting about Dave and I is Dave came from the insurance and financial side, and I was a hospital CEO. And so to compare notes and start to open each other's eyes to kind of how it's seen from the other side, Dave really won me over, and it was a lot of his pals that won me over when he copied me on this email in preparation for the film, the documentary he's making about healthcare affordability in America. And I can't wait for it to come out. But that's where I first saw his name. But some of the things I learned from all these brokers, longtime brokers on this email, were really eye-opening, that the different ways in which brokers will make money off their clients. And some of them seemed, I'm trying to be nice here because I don't want to upset or offend brokers, but they seemed real sneaky. So, and again, I'm always careful not to attack brokers, because as Dave said, in the traditional sense, he's a broker, but he's also the new age broker. So Dave, tell me one or two tactics of the past, whether you used them or not, that you just go, wow, I could never do that to a client, that any employer should just be aware to look out for, kind of in the fine print, or sometimes not even in the fine print, right?
Yeah, sometimes it's really hard to track it down. I'll tell you the couple of areas that really strike me as wrong is, number one, if I wanted to, I could get 50 cents or $1 for every time any one of my clients' employees fill a prescription.
Wow. So give me another example.
Going on right now. That is, okay. Another example, I was contracting with a stop-loss vendor, and they said, hey, we're getting ready to send...
Real quickly, just can you give a 30-second definition of stop-loss for our listeners that aren't familiar?
Sure. So almost all of our self-insured clients, a lot of employers think self-insured is riskier. That's not true. Every self-insured client that we work with has a stop-loss policy, which protects the employer against large claims, and the limits are all based on the size of the company, their cash flow, and so on. But it's not health insurance, because it's not paying for health care. It's reimbursing the employer for health care they had to pay for their employees. And it's really important to understand that, because if you don't have an advisor or a consultant that really knows stop loss, it's easy to set up a stop loss policy in a way that puts some significant potential liability on behalf of the employer. So all of the horror stories I've heard have just been inappropriately set up stop loss.
Wow. Yeah, I really learned a lot from listening to some of these different stories on the broker side. But what I will share with you, as a former hospital CEO, I maintain good relationships with the hospital community, but I'm also a champion for transparency, which obviously has been lacking. But I'm excited as folks like David and I are amongst a handful of people nationally that are really constantly committed to keeping this on the forefront of the discussion, this transparency, this affordability issue, this something has to be done. We've reached the tipping point, but only the employer can declare they've reached the tipping point, right? Yep. We try to keep it on the forefront, but hospital transparency is a big problem that I have made a personal mission of mine to consistently bring up. There's some great stories, and one of the stories I tell in Health Wealth is about driving up to a stoplight on your daughter's 16th birthday. She printed out exactly the car she wants. She gets to the stoplight. She looks to the left, and there it is, down to the exact color and T. And then she looks to the right and says, there it is too, on a different lot. On the left, it's $16,000. On the right, it's $42,000. And here's the question I always ask, and I'll ask you, David, which way are you going to turn? Because when your insurance, quote unquote, paid for it in the past, most people were going to turn right, pay more, and ask questions later.
Yep.
And when consumerism or consumer-driven healthcare kicks in, you're going to go left and say, what's the difference? And the sales guy's going to laugh and say, just the price. That's it. It's about 60% cheaper, but nobody ever asked when the insurance paid for it. So tell us a little about consumer-driven healthcare and how you see organizations championing this. Because before I get to the 9 steps in my book, part 2 is actually separate. It's about, hey, you can't do any of these things. You aren't going to be successful without consumerism when your employees committing to it, number 1.
Yep.
And number 2, if you want your employees to be successful, you must create a health wealth culture within your work environment. So talk a little bit about that and what you've seen with clients who have engaged the consumer-driven healthcare process and some others that haven't.
So we take a little bit of a different approach to consumer-driven healthcare. So we are not big believers in HSAs, at least the way in which they're traditionally rolled out.
Can you real quick explain the HSA 10 seconds?
Sure. It's a high deductible health plan where everything goes to your deductible except preventative care. It has to have minimum deductibles set by the IRS. And when you have that type of plan in place, you can open up a bank account and put pre-tax money in, or your employer can put pre-tax money in, and you can spend it tax-free on medical expenses.
I've had plenty of HSAs, but because I'm new to this whole thing, when you use a term that I know is new to people, I go, hey, hold on real quick, explain that. So keep going from there. So answer that question about consumer-driven healthcare, if you would.
Or idea. Yeah, so the concept or idea of an HSA makes a lot of sense initially, but the problem is, like you said, you can't get a price. And so how can you be, if you don't know it's 16 over here and 42,000 over there, how do you even make that decision? Because I'll give you a quick story. 3 weeks ago, I had a hernia repair, an inguinal hernia fixed. And I made a whole video out of it. It's not edited yet, but I'll send you the link when it is. But I called all of the 4 big hospitals near me, and I said, I have an inguinal hernia on the right side of my groin. It's CPT code 95856, and I would like to know how often you repair it, how well you repair it, and how much it costs. Well, none of them could give me any info on how well and how often, but I did get some pricing. They could only give me the facility price. Then I had to call the anesthesia, get the anesthesia price. Then I had to call the surgeon, get a surgeon price. I couldn't get any pricing from the surgeon, but I did get facility and anesthesia. What was the range? $8,900 at the low end, $47,000 at the high end. Those were the high and the low. Now I chose to go to Oklahoma, the Surgery Center of Oklahoma, which is in Oklahoma City. It's owned by a guy named Dr. Keith Smith. All of his pricing is on the homepage of his website, as well as his quality and frequency statistics. So they had done almost 400 hernia repairs in the prior 12 months. They had had 0 complications, 0 readmissions, and 0 redos. I went to a surgeon that does these all day long, and Surgery Center of Oklahoma's pricing, including facility, anesthesia, and surgeon, was $3,050. So it was actually cheaper for me to not use insurance at all, to pay for the plane ticket, pay for the hotel, and fly to Oklahoma, because the total cost was $4,000. That's less than most people's out-of-pocket are under their health insurance plan. And that doesn't include the fact that my health plan didn't pay on top of that, which would then be for this new plan. So our definition of consumer, so the way that we've evolved currently, and I think that this is going to change as time goes on, but we say to employees, hey, if you go to a place like Surgery Center of Oklahoma, and you don't have to fly to Oklahoma, there are places throughout the country that do this. I just use that as an example because they're the pioneer of this. But if you're an employee on one of my plans and you go to a place like Surgery Center of Oklahoma, your employer is going to pay 100% of everything. You're going to pay nothing. They'll even pay for your travel. Because I say to the employer, hey, would you rather pay 100% of, let's call it $4,000 with travel, or 70% of $47,000? Which would you prefer? Yeah. So it's really that simple. It's become very difficult, I found. And initially, I hoped my original theory was get the patient to want to know the pricing and want to know the quality and let them make the decision. But I don't know that we have access to the information yet for that to really be a reality. For the plan for people. And we're saying to employees, go over here and pay nothing, go over here and pay what you've always paid. It's no different. And the one positive effect of these sky-high deductibles and out-of-pockets is that making something zero is a really strong incentive, whereas when back in the day when the deductibles were $250, it wouldn't have been as strong of a lever.
What a great example. A couple things that came to mind, and I'm trying to remember them off the top here, but 9,000 versus 47,000. So I mean, it's 5 times more, and some people are shocked when they hear those numbers, but that's routine. That you see that anytime you do the price shopping, which is why consumerism is so important in your organization. The other thought that crossed my mind, and I write about this in the book, and there's an article I'm going to post on social in a couple of weeks that was actually, it's a couple months old, but it's about Santa Barbara County in California taking all of their surgeries 3 hours to the south to San Diego. They always also give an option to go to Seattle, to Virginia Mesa, or another good hospital. But the point is, and as an executive of a hospital for so many years, this is what cracks me up. I'm on committees with the county board of suit folks, and I'm golfing with them, or I'm at the country club, but not me, but I'm just thinking, I see these people once or twice a month, and the guy's gonna say, hey, I'll be on a committee with you, but I'm taking all of the good business that you get from me 3 hours to the south, because it is a $50,000 gap. It can be $100,000. It can be 5 times the price. And so the point I want to make that David made very well is people in America hear the term medical tourism, they immediately think of Costa Rica or India. That's really not where we're seeing a huge amount of medical tourism. We're seeing it from county to county, or as David pointed out, a flight from North Carolina to Oklahoma, which saved him a minimum of $3 or $4 grand and up to $40,000. So does that make sense? These folks in Santa Barbara are getting 4 or 5 nights free at a great resort in San Diego County. They're getting a higher quality hospital, even though their hospital in Santa Barbara is quality. That is the type of medical tourism that corporations are looking for to drive down their costs. And as David pointed out, here's the best part. If you engage and you go to your employer and say, hey, I found a place that it's only $4 grand, will you pay the entire fee? Because 100% of $4 grand is way better than 70% of a lot more. So great example. So David, the main point of this show is to talk about examples like this that can help people reduce their corporate and their personal healthcare spending. Tell me specifically what your company is doing. Maybe give us a couple examples that are helping do that for businesses primarily, but also almost always the employee benefits as well and saves.
We have our strategies. They must hit all 3 of these stools. They must lower plan or employer cost. They must lower employee cost at the same time. And that right in of itself is radical, because if you're an employer coming from a fully insured mindset, you're used to a seesaw where if you want to make benefits better, it's going to cost you more money. And if you want to save money, you've got to make benefits worse. So we actually have the ability to do strategies that do both simultaneously. And then the third thing is when quality is a factor, and it isn't always a factor, but when it is, we want to improve outcomes. So those are our 3 kind of pillars of the stool: lower cost of the plan, lower cost of the employee, and better outcomes. And there are a lot of strategies that do that, one of which is putting on a bundled price, prearranged, transparent surgical network for those outpatient procedures and surgeries, of which Surgery Center of Oklahoma is 35 miles. So we're not even talking about having to hop on a plane. The average is 35-mile travel to get to one of those places on average. So to come to an employee who's making $30,000 or $35,000 a year and say, hey, now you can have your knee surgery that you've been putting off at 0 cost, and now we can get that employee back to work healthier and better than they were before, that's good for the employer, good for the employee. We do a lot around pharmacy. We bring in some special mail order pharmacy programs that are completely outside of the traditional PBM and retail channels that save anywhere from 20 to 70% off of medications. And we give those to the employees at 0 cost when they order it through one of those programs, because again, we have a medication adherence problem in this country. We have people that are splitting pills or taking their insulin every other day because they can't afford supposed to. Again, lower the cost to the employee simultaneously in programs like that. A responsible TPA can make a huge differential. I think employers take the TPA decision way too lightly. They should go and visit the TPAs they're considering before they even sign up with them. And they should not worry about the per employee per month cost. There are a lot of the big TPAs, who shall go nameless, that deflate their per employee per month cost because they're getting money in all this sort of back end sort of way. We require our TPAs to be contractually obligated to only receive the administrative fee as their only source of revenue. And so that means a higher administrative fee. They've got to be paid fairly for what they do. But the fixed costs, the administration costs and the stop loss and the PBM, those only equal 20 or 30% of a company's healthcare spend. We really focus on that 7. We're 20 or 30% to properly manage that 70 or 80%. And when that's done properly and we reduce 20% on 70%, that's a heck of a lot better than reducing 20% on 20%. I mean, the numbers just speak for themselves, but yet brokers and employers are so focused on that fixed cost side of the equation, which I understand it spreadsheets nicely. It's a little more difficult and a little more abstract over here, but this is where the money's going.
So I'm hearing through the grapevine that there's a number of hospitals in California, where I am, that are going direct to employers to set up arrangements, which is something that I wrote about and talked about often. Is there a role for the traditional broker in that process, or do you anticipate that the whole goal is to kind of quote unquote cut out the middleman? Are they capable of pulling this off, and is it being pulled off?
You know, my feeling is that, first of all, a lot of brokers, I put myself in my former life into the category that I'm about to describe, but most brokers are looking out for themselves. Most carriers are looking out for themselves. Most hospitals are looking out for themselves. I think if the broker were properly compensated and properly educated in our healthcare space, that they should be the ones to keep all those people in check. My fear is if an employer goes direct to a hospital and, let's say, creates plan incentives that drives people to that hospital, then that hospital first of all, you need to validate the pricing to begin with. Am I getting a good deal by sending everyone there? And then you need to make sure that those pricing gets kept in check. Every time we've turned power over to a hospital system or an insurance company in terms of pricing, they've failed miserably on that historically. And so my fear is by giving them this unchecked power, there's a deficiency there. But again, if you have gasoline on fire, so I think a proper broker can play a role, but I think most brokers as they currently exist wouldn't add much value to that scenario.
So I've always wondered this, just being a hospital CEO by trade, and now I teach healthcare policy at USC. So the insurance piece, I've been at arm's length from it, and the broker piece, the carrier piece, all that. So I always wondered, so let's take a small rural town, let's say in Iowa, 20,000 people, but there's not much for 2 hours, 3 hours in each direction by car. I always wondered what percentage of the healthcare dollar the employers there spend and the individuals, the citizens spend, that leave the market. And so my question would be, if you had to guess at what that percentage is, and would they be able to kind of quote unquote blow up the model and start over by keeping all that money in town? Is that something that's even feasible?
Absolutely, I think it is, but it really depends on the mindset of the management of that local hospital and that facility. And I think if the employer is going to pony up to the table and even enter into these conversations, they better be willing to put the money in to send their employees out of town, even if it requires a private jet or an airplane or whatever the case may be, because that's what's going to give you the leverage and make them understand that you're serious about it. And so if you can go to that hospital and it's the right mindset CEO and say, we want to create a community partnership here, but that doesn't mean just providing good care, which you already think you do, and I think we need to validate that. But it also means charging reasonable prices as well. And if you can make it so it's financially beneficial for us to send our patients here, one of the most powerful things that we can use as negotiating tactics with the hospitals is to say, hey, if you do certain things, completely waive the employees that come to you, because we know they're writing off a lot of bad debt these days. And so by eliminating that from the plan for that hospital, you gain a lot of leverage in terms of pricing. But it's got to be win-win.
Well, and what's interesting to me is I'm sure there's an unemployment issue in that small town in Iowa, that hypothetical town as well, right? So I love the concept of people thinking that out of the box, because one of the chapters in the new book is called, a system broken beyond repair. It really is broken beyond repair, and that's what I love about the approach you take and some of the others, to say, hey, let's just start from scratch and see what makes sense and recreate if we have to, instead of just putting more Band-Aids on a system that was broken years ago that's become more and more broken. So, David, tell us where people can find you if they want to look you up.
Sure. LakeNormanBenefits.com, or I'm very active on LinkedIn, so just David Contorno, C-O-N-T.
Well, I'm looking forward to...
Great way to stay in touch. I put out thoughts.
Sorry to interrupt you. I'm looking forward to your video, too. I think you could make a real powerful video. And I want to say I already saw a post from you that summarized your trip to Oklahoma, because that sounded awfully familiar. And stuff like that gets me so excited, because we need benefits like this to open folks' eyes to the fact that look, guys, you shop when you buy a house, you shop when you buy a car, and it's really as simple as price and quality. There's not much more to it. It's
Right.
not rocket science, just asking questions. But I want to latch on to that example David gave before I asked my last question, which was he called the hospital with the exact code for the procedure he needed, and they could not and would not answer his question. I used to be their boss, I know. I didn't want to equip those folks with that information. Many of them probably didn't even know what a CPT code was, because we've never empowered them to engage in the discussion. In fact, usually what they're taught to say is, well, your insurance is going to pay for it anyway, aren't they? And so when David finally got to a hospital that has actually done the right thing and taken some accountability and prioritized transparency, they were still only able to give him the hospital component, which means he's got to make at least 2 more phone calls. We've already found that 1 phone call doesn't take care of it. 2 more phone calls to find out what anesthesia and physician components will be. They do not want you to know the answers to these things, but I believe that I've engaged in this kind of battle, if you will, with Dave Chase and Dave Contorno and so many others around the country about keeping this storyline prominent, because we have to, until consumers realize that if you don't shop for healthcare like you shop for a car or a house, you're going to continue to drive everybody's price up. It's as simple as that. I've written several stories on LinkedIn that say Trump, Obama, Hillary. It doesn't matter. Costs are going up until patients engage in the process. Go ahead, David.
I'd like to comment on one thing, and this is an important mind shift here, that there's a lot of people that would listen to what you just said, shop for healthcare, and say, oh, wait, I already do that. Every year I look at all my insurance options and I consider them, and I look at the different deductibles and what comes out of my paycheck, or I go on the marketplace and I compare the plans side by side. One of my big missions in this world is I'll go into an employee meeting and I'll say to them, hey, everybody, who's your healthcare provider? And their answer inevitably is Blue Cross or United or Cigna. And I said, guys, Blue Cross doesn't provide any healthcare at all. What you just did would be like if I asked you what kind of car you drive and you said Geico. Okay? One of my missions is to separate healthcare and health insurance. We don't do it in any other segment. If you said to someone, go shop the price of your car, they're going to actually shop price. A lot of people are going to go shop their insurance, not the care itself. And I always say that our insurance is expensive and crappy in this country, no doubt, but it's not the cause of the problem, it's the result of the problem. And we need to fix the cause, which is to the point of our whole conversation, which is the actual care, the cost and quality of care that we receive.
Agreed. I had a post on LinkedIn last week, and I think David chimed in on it too, about what I called EHCs. And if you've listened to the podcast and radio show, all the episodes to date, We have an entire episode on an EHC, an engaged healthcare consumer. I want to make that term well known to people. Are you an EHC was the name of the post. Actually got some pretty good traction and continues to. And that's what David's talking about, is becoming an EHC, an engaged healthcare consumer, engaging in the process. And if you're an employer, a boss, look, our whole goal right here is to help you understand how to encourage that behavior from your employees, and that's by creating a health wealth culture, is how I refer to it, making it easy for your employers to do that, having that information accessible for them, doing all these things that you can learn more about. So we're just about out of time, but I just want to ask David, I know this is an impossible task to wrap up on, but can you give me the 1-minute explanation of how you, as a Healthcare Rosetta affiliate, would describe the Rosetta and what it is?
Yeah, first of all, it's transparency in every way we can get, in how we get paid, where the dollars are going. It's transparency across the board. It's aligned incentives. So it's making sure that everyone benefits from the interests of the client, the patient, the employee, the employer. And then it's value-based care. It's investing more in primary care. So the point where all that a primary care doctor serves as is a gateway into the more expensive parts of the healthcare system, and they push you into that. That's what they're designed to do. That's what they become designed to do. So how do we bring value back to that primary care space? And then the fiduciary component. I mean, I think employers need to think of the health plan ID card their employees carry as though it's an unlimited, unchecked corporate credit card sitting in their pocket, because that's really what it is. And if someone were carrying a corporate American Express card for the company, what kind of rules and triggers would you put around it? A lot of employers say, well, we don't want to tell our employees how or where to get care. I think by not doing that, you're breaching your fiduciary responsibility. You don't let your employees stay in the Ritz-Carlton when they travel for business. Well, don't let them pay Ritz-Carlton prices for their health care when the value or quality isn't there to justify it. And these employers are making decisions that unwittingly allow their employees to do that all the time. So employers need to not be afraid to change. I can't bring you 40% reduction healthcare to bring that. What I can tell you is the Band-Aid that gets ripped off, it's a little painful for a few months, but once we get past that, and it's pretty quick, we wind up with more engaged employees, healthier employees, better affordable access to care for the employees, and better benefits for the employer to attract and retain top talent.
Awesome stuff. So I said that was the last question, but I have one more. I'm going to start a tradition here on the Health Wealth podcast and radio show. What is your favorite sports team, whether college or pro? Give something to some folks something to remember you by.
I'm ashamed to admit it this year, but I'm a New York Giants fan. Have been for a long time. They were second to last in the league, but you know what that means. We get a good draft pick this year, so hopefully we come through it and come through it next year. But I'm a big Giants fan.
Yeah, I teach at USC, and there were folks wearing Giants jerseys in LA with both Rosen's name on the back and Andy Arnold's name on the back even before the draft. So cool stuff. Well, hey, it's been great getting to know you, David. I'm kind of taking the David Letterman approach of not speaking to some of my guests and not meeting them until we're on air. I know Dave Letterman was famous for that, because it's been cool for me to just get the real candid answers from you. So thank you, David, for connecting on LinkedIn with me and for sharing with the audience here. And we'll hopefully have David back on again in the near future. So thanks again for joining the Health Wealth podcast and radio show.
Thank you, Josh.
And Dan, as my editor, I'm going to just do the sign on real quick, because I think I screwed up the first 1 minute. I don't think I had video on. So I'm just going to give you a disclaimer to record before I stop real quick. Hey guys, Josh Luke here with the Health Wealth podcast and radio show. Forgive me, I'm new to this. It took me about 3 or 4 minutes to figure out how to click the video button on this Skype recorder to get David Contorno in here, but he is, you are going to see him in the flesh, not just a still shot. Just give it about 3 or 4 minutes, listen for the first few minutes, and then it'll kick in. Thanks so much.